So, good morning, everyone. So, today I'll be taking a class on the mandibular fractures. So, what is a fracture? A fracture is a break in the continuity of bone with or without loss of bony contour. When stretched or bent beyond its elastic limit due to any trauma or any pathology is referred to as fracture. The mandible is the second most common fractured part of the maxillofacial skeleton. So, what is the etiology? Vehicular accident, that is the road traffic accidents, accounts for around 43%. And then there can be assault or interpersonal violence, fall, sports accidents, industrial mishaps or work accidents, and pathologic fractures, which account to around 2%. There are various classifications of mandibular fractures. The Kruger's general classification, it classifies fractures as simple or closed, compound or open, comminuted, pathologic fractures, green stick fractures, and impacted fractures. So this is the diagrammatic presentation of fractures. Then there is Rose and Kelly's classification. Fractures not involving the basal bone and fractures involving the basal bone, which can be single unilateral, double unilateral, bilateral, and multiple fractures. This is the Dingman's and Natwick's classification, where he classified fractures into the different regions like the symphysis, canine, body, angle, coronoid, condyle, and dentoalveolar region. So according to the direction of fracture and favorability of the treatment, the fracture can be classified as vertically or horizontally favorable or unfavorable. Now, it is important to understand a fracture is horizontally favorable when it is viewed from a horizontal direction. It is vertically favorable when it is viewed from a vertical direction. So what makes it favorable or unfavorable? Like in the first picture, you can see the fracture in the angle region runs from posterior to anterior, and the muscles acting on it are the masseter muscle and the medial pterygoid. So if you see this picture, you can easily come to know that the masseter will pull it upwards and the medial pterygoid also will pull it. So when they will pull it, the fracture segments will approximate. So that is why it is a favorable fracture. Now in the second picture, you see the fracture line is running from anterior to posterior. And when there is a pull of the masseter and the medial pterygoid, the fragments are displaced. So this is a horizontally unfavorable fracture. Similarly, in the third picture, you see the vertical favorable fracture, where the pull is from the lateral pterygoid and the medial pterygoid. And in the last picture, you can see this is a vertically unfavorable fracture, because when there is a pull from lateral pterygoid and medial pterygoid, the fracture is displaced. Fractures also can be favorable, unfavorable in the anterior mandible as well. And the muscles which mainly act are the mylohyoid, the genioglossus, and the geniohyoid. They will pull the fragment towards the hyoid bone behind. Then there is Kazanjan's and Converse classification. They classified it according to presence or absence of the teeth on the each side of the fracture line. Class 1 is when teeth are present on both the fracture fragments. Class 2 is only on one fracture fragment teeth are present, and class 3 is edentulous. Then there is AO classification or FLOSSA, where F signifies the number of fractures, L is the location of the fracture, S is the status of O is status of occlusion, S is the soft tissue involvement, and A is associated fracture of the facial skeleton. So what are the steps? First is preparation, triage, primary survey, that is maintenance of A, B, C, D of trauma management, resuscitation, adjuncts to the primary survey, secondary survey, and definitive care. So in the initial survey, you have to maintain the airway, breathing, circulation, and disability management, and then exposure and environmental control. Like you can go for chin lift or jaw thrust procedure to maintain the airway, remove any foreign body if it is there, and evaluate the patient. Detail of the clinical history should be taken, whether there is any loss of consciousness, whether there is any ENT bleed. Okay, so these should be considered. If there is loss of consciousness or history of vomiting, then you have to go for a neurosurgery referencing. How the patient had that injury. In the first picture, you can see there is a blow on the right side of the jaw. So what type of fracture do you suspect? it can be either a parasymphysis or a body fracture. If the patient has a blow on the chin, okay, there's something known as counter coup injury. The forces from the chin are directly transferred to the condyle. So there can be a symphysis fracture and also bilateral condylar fractures. And if the patient hits the dashboard of the car, then what can happen is bilateral condylar and bilateral parasymphysis fracture. So taking history is very important. The signs and symptoms of mandibular fractures can be, first is Coleman's sign, that is the lingual hematoma, especially in the anterior mandible. Change in occlusion, there can be paresthesia or swelling can be there, or extraorally on the skin, ecchymosis can be there. And then there can be step deformity and lacerations or hematoma, mobility of the teeth, crepitus, and palpable bony movements. So the picture represents the weak areas of the mandible, that is the neck, the symphysis, the tooth socket, which is impacted tooth socket in the second picture. That is also a weak area in the angle region. So these are the clinical pictures showing hematoma, swelling, and ecchymosis in the chin region. Then in the first picture, you can see there is deranged occlusion. In the second picture, you can see there is step deformity in the symphysis region. Again, in the third picture, there is a step deformity. In this picture, you can see lingual hematoma, also known as Coleman's sign. So there are various radiographs you can go for diagnosis. OPG, lateral oblique view, AP view, PA view, and lower occlusal views. And you can go for CT scan or 3D reconstruction, along with the coronal, axial, and sagittal views. So the first picture shows the angle fracture in the PA view. Then second picture is the OPG showing the body of the mandible fracture. And this one shows again parasymphysis fracture, the third picture. Then this is the CT scan showing the fractures of the zygomatic process of the maxilla, the mid-palatal split, and in the mandible you can see the symphysis comminuted fracture. So then you have to go for definitive management. So what are the 3 steps? Reduction, immobilization, and fixation of the fracture fragments, prevent any kind of infection, and rehabilitate the patient. So this is a gunning splint. It is mainly used for edentulous patients. And historically, people used to put Barton's bandage, which is shown in this picture, diagrammatic representation. So what are the indications for closed reduction? When you have to go for closed reduction? Non-displaced favorable fractures, grossly comminuted fractures, and if the patient has a contraindication for open surgery, you can go for closed reduction. Mandibular fracture in children with developing dentitions, the coronoid and condylar process fractures. In condyle process fractures, where it is a high condylar fracture, intracapsular, you can go for closed reduction. What are the indications for open reduction? Displaced unfavorable fractures, multiple fractures are there, and if edentulous maxilla is there opposing a mandibular fracture, then you have to go for open reduction. If there is malunion or systemically if the patient is not fit for closed reduction, then also you have to go for open reduction. So now we come to closed reduction and indirect skeletal fixation. There are various wiring techniques you can use, like the direct wiring, interdental eyelet groups, button wiring, residence wiring, Gilmer's wiring. Then there is arch bars. The different splinting techniques used are gunning splints, cap splints, which can be metallic or acrylic, and also arch bars. So this is the Gilmer's direct indirect wiring. This is residence arch wire. This is again Brittle's wiring. And this is IV loop method, where the loop whose internal diameter is around 3 mm. From there you can pass the wire for intermaxillary fixation. It is usually done in the premolar region, premolar molar region. So this is again IV loop method of IMF. This is the Stout's method. If there is a single tooth remaining, you can go for a clove hitch. And then there are arch bars. The indications are when insufficient teeth are remaining. Teeth present are so distributed that intermaxillary fixation is not possible, and when lab and technical facilities are inadequate, to reduce the preoperative time which would otherwise require cap splint preparation. So these are the various types of arch bars, the Eric's arch bar, the Jelenko arch bar. And in the second picture, there is rigid IMF by using wires. And then you can also go for elastic intermaxillary fixation in the third picture. And you can also go for intermaxillary fixation using screws, IMF screws. This is a picture of a gunning type of splint where patient's denture itself can be used as splints. In children, pediatric patients, for fractures of the mandible, you have to go for circummandibular wiring. This is the technique where a bone awl is used. A small stab incision is placed at the inferior border of the mandible anteriorly towards the side, and then a bone awl is inserted lingually. You have to keep in mind, you have to be very close to the mandible, just touching the mandible, and then you take out a wire from that owl, turn it, and then again, without taking the owl out, you have to you have to go around the mandible and come out from the buccal aspect. This is clearly shown in the picture. In the third step, you come out and then you put the splint there, do this bilaterally, and then you tighten the splint with the wire. So this is circummandibular wiring. This is the clinical picture of a circummandibular wiring. Here, acrylic splints stabilized by circummandibular wiring. Now we come to open reduction and direct skeletal fixation. You can go for transosseous wiring or bone plates. Bone plating systems can be, you can go for mini plates, which is a non-compression plating system. Then you can go for compression plating system, direct compression plates, or eccentric direct compression plating system, intramedullary pinning, titanium mesh implants, circumferential straps, bone clamps, and bone staples and bone screws. So the first diagram shows simple wiring technique. The second one shows figure of 8 wiring and transosseous circummandibular wiring in the third picture. Now we come to rigid internal fixation. The examples are use of 2 lag screws, reconstruction bone plates. Okay. So what is compression plating system? Maximum compressive forces of up to 300 kPa per centimeter square can be applied by a direct compression system. Ideal location is at the region of the maximum tension, that is the superior border, but due to presence of tooth root or inferior alveolar nerve bundle, this is not possible. This is a plate is inserted at the lower border, but we all know that mandible has 2 types of forces. There are compression forces on the inferior border and tension forces on the superior border. So to combat the tension forces, you usually place a arch bar at the superior border and do the plating at the inferior border. So this is a compression plating system. The disadvantage is it is very bulky. Then there is dynamic compression plating. This diagram shows the dynamic compression plating. The transverse screw hole, there's an inclined plane within the hole in the plate. So when you place the screw passively and when you tighten the screw will glide. When the screw glides, both the bone fragments, they come together. So there is compression bone plating. So this is again explaining the procedure where the special drill guide is used. The drill guide positioned to a place where a screw is placed in a passive position within the oblong hole of the plate. The drill guide position to place screw in the active position, and design of the oblong hole in the plate, hemispheric shape of the screw head, and eccentric placement of the hole all lead to displacement of the plate in the direction of the arrow as the screw is tightened. So this brings the bone segments together. Then there is eccentric dynamic compression plates where there are 2 screws, inner screws and outer screws. The inner screws impart compression at the inferior border, and the outer screws, they impart compression at the superior border. This is how it is done. Then you can also go for lag screws, mainly used for oblique fractures. So what does lag screw do? It basically engages the inner cortex. There are 2 fragments of the fracture. So the inner fragment, it basically engages the inner fragment and pulls it. So both the fragments, they unite. So this is a normal screw in the first picture. In the second picture, it is a lag screw. So the A is the normal screw, the B is the lag screw. We can see there are indentations in the inferior part to engage the outer cortex. Then there is monocortical mini plate osteosynthesis. So mandible acts as a parabola with a thicker outer cortex and thinner inner cortex. The basic principle is to fix plates along the Champy's lines of osteosynthesis. Champy's lines run from the external oblique ridge, okay, and then it goes down, and then again at the symphysis there are two tension lines. So according to Champy, if you place one osteosynthesis mini plate in the external oblique ridge, it is sufficient. If you're going for an open technique, intraorally, if you go for one plate in the external oblique ridge, then it is sufficient. But if you're going in open technique, you can place two mini plates, one in the superior and one the inferior. And then when you are plating the symphysis, you need two bone plates according to Champy's principles. In parasymphysis, one body also one. What is the difference between direct compression plating and mini plate? In direct compression plating, there is primary healing. And when you are placing mini plates, there is secondary healing. That is, first callus formation will be there and then it will convert into bone. So these are the Champy's lines. So what is the absolute indication for plating? Displacement into the middle cranial fossa, impossibility of obtaining adequate occlusion by closed reduction, then you have to go for open reduction. Lateral extracapsular displacement if it is there, and invasion by a foreign body is there. Then there are resorbable plates. You can see in this diagram, resorbable plates are also there, which are made from polyglycolic acid or polydioxane. So what are the complications? Malunion, non-union, delayed union. Okay, and during the surgery, there can be hemorrhage, and there can be nerve injury, growth alteration, and TMJ dysfunction. Thank you.